Awake surgery has been performed now since years 1950s. Started with a different kind of surgery. Right now, in the last 20, 30 years, it became one of the most useful procedure for oncology surgery. And still, that's a funny thing about the brain, that is the only organ that senses all the other organs, but still it lack of its own sensitivity. When we operate on the brain, the patient still will not feel anything about pain because we are working on the brain. So that allows us to do awake surgery, because the patient doesn't feel any pain when we touch the brain, but it feels what are the stimulation that we may do on the brain for different purposes, and because we want to have a monitor about some specific function. And in particular, the awake surgery for oncological purposes was started mainly to monitor the language function, because for other kind of function like motor function, you can do still procedures in a sleep patient with just neurophysiological monitoring, and that's enough to monitor the motor area or the motor function. When we comes to language, that is a very, very complex function, maybe one of the most complex one. You need to have the patient awake, because you need to the patient to do different kind of activities and to test different kind of skills that are related to the language, and you can do this only when the patient is awake. Patient who has a tumor involving the language areas. So nowadays we're not talking anymore about specific language areas, but with the connectomics, we know that we started learning when I was in the medical school that the BRCA areas was for the production of language, while the Wernicke's area was for the understanding. But the question is more and more complex. So anytime a patient has a tumor involving the circuit of language, so that can be the circuit of the phonemic function, or the circuit of the semantic function, so the one that allows us to understand what the language is saying in that moment, we propose an awake surgery, because it allows us to preserve not only the area but still the connection that are more important than the area. Because we are seeing in a young patient that you can also remove a tumor that is involving a cortical area, language cortical area, and still, thanks to the neuroplasticity, maybe the patient can recover that function, because other cortical areas can take that function. But when you give a damage to the fibers, so the tracks that are connecting the different cortical areas of the language, the patient will not recover from that damage. It's very important to keep the connections safe and not damage it through the surgery. So we propose awake surgery for all tumors that are involving the cortical areas or the connection of language. The choice of the patient is very careful. The patient need to undergo different tests, psychological tests and psychological evaluation to really assess if they are able to resist in the OR during an awake surgery. But the most incredible thing that I still remember, very, very few patients who refused to do awake surgery, or during the surgery decided to stop it. Once the patients are in the OR, they are fully collaborate most of the time. So that's a good thing. So So when the patient, we have a protocol that is called asleep, awake, asleep. So during the first phase of the surgery, the patient is asleep once we open the skull and we reach the brain. Then the patient comes awake, and it's the moment when we perform the cortical mapping, or we perform all the tests we need to do during the surgery. And that's the most critical part. Sometimes, you have a window that is coming from 20 to 30 minutes when the patient is fully collaborative. Then they get tired, so they are not fully understandable, or you don't understand if what you are causing with the stimulation is a deficit, or is the patient that gets tired. So we know that we have that window, and in that window we need to maximize our testing. We need to try to find all the limits of the tumor to know where we can go safely or where we can have to stop. Sometimes we really have also the anesthesiologic team that is prepared to do awake surgery, so they always try to feel the patient comfortable also with the pain that can be given by the skin that is opened. And we also have the nurses that are comfortable with dealing with an awake patient in the OR. So this team works together since 20 years. So they really the patient really feel comfortable in the OR when they are doing awake surgery. Sometimes in few patients we needed to stop. So in that cases, we prefer to stop the resection if we know that we are in a very critical area, and do the surgery again in 1 or 2 months. And this was the treatment for a patient that with an insular tumor. We needed to stop the part on insula because the patient got tired, and then we came back in 2 months to remove the other part that we left behind. So it was a final good result. We were very, very happy with that. But you have to respect the patient and what is going through. So that comes before any kind of surgery. So it's the patient that guides you if you can push it a little bit farther, or you have to stop. In awake surgery, that of course the technology is giving some important results, and also especially of functional MRI that are becoming more and more precise in giving the cortical areas or the connection of the fibers that are involved in the process. And I think that also artificial intelligence will contribute in this in the imaging part that is very important for our job. 3D modeling, of course, is important because having a real 3D model in your hands and not a 3D reconstruction that you can see in the screen is always good for a surgeon. So you can fully understand the case before you go to the OR, make some kind of simulation for the approach. So it's very useful. We need 3D models in oncological surgery as we need them in the vascular surgery. So I think that it's important for the expert surgeons to get fully prepared for the case in the OR, but also for the training of residents or students. That is easier when you can show them on a real 3D model than on a screen. I think that new techniques, maybe we are proposing some of them that is not a technique, but is some kind of psychological test for sensory areas or complex functions such as proprioception. I think that surgical technique in per se has not changed over the last years. We use the same surgical instruments. Maybe you can use now the exoscope or the microscope, but still that doesn't change much on the technique. Now we are also developing some kind of special electrodes to recording from the cortex that are very, very small and very sensitive. This will be developed with a project with the National Institute of Technology, not just for recording the activity, but to differentiate the brain tissue from the tumor tissue. So, because in some kind of tumors like low-grade glioma, sometimes it's very difficult, differentiate the brain from the healthy the tissue from the tumor tissue. So in that cases, with this kind of special micro electrodes we are we are developing, it should be easier to know in recording the activity of the cells, if that is tumor of its brain. So it can extend your resection, of course, if the functional stimulation allows you to do that and you are not entering in one of the eloquent area. So, I mean, the technology is always good. It gets time to fully enter the surgical practice, but I think that it will improve in the next years our activity. One of the main risks is the seizures, because cerebral activity when the patient is awake, of course, is higher than when you have it asleep. So we do corticography with our colleagues and neurologist colleagues. Anytime we get signs of cortical activity that is not normal at that stage, we provide with antiepileptic drugs or cold water. So this is, I think, this is the main risk of awake surgery. Then, of course, you have a higher risk of bleeding because the patient, the blood pressure cannot be fully controlled when if you compare it to the asleep patient. But these are the main risks different that can be different if compared to the asleep surgery. The other risks are part of any kind of surgical procedure. I hope that for the oncological brain surgery, surgery will become only a smaller part of the process. I hope that. I don't think that for tumors like gliomas, the answer for the treatment is surgery. It must be something that it kills specifically all the cells of the tumor, and with surgery still you cannot do that. So I hope that chemotherapy will, some kind of new drugs will improve the outcome of the patient. Surgery is still important for the mass effect of the tumor, but the real treatment needs to be a chemotherapy, a drug that can easily reach all the cells that are tumor cells. For surgery, we try always to improve final clinical outcome of the patient. That means that we want the patient coming back from the OR at least as he entered the OR from the neurological status. So we don't want to give patient a neurological deficit or give them something that can be worse for their quality of life. So the philosophy has changed over the years. In 30 years ago, the role of the surgeon was to take away all the tumor with no respect of the neurological function. Nowadays, we prefer to leave some tumor behind, but the patient can have a quality of life that is significantly higher than take out all the tumor and the patient needs to be in the bed for the rest of his life. So this philosophy has been changed, and I think that this is the good direction. So I hope new technology will help us to improve the final outcome of the patient. I think that artificial intelligence will give us a very significant shot with the algorithm for the diagnosis or treatment. So I think that it still is something artificial that needs to be checked by the human. And our to be a surgeon or doctor is not only skills or protocols or numbers, so we need to stay on our human part and take care of that. But artificial intelligence can give us a very big hand in improving the outcomes. You can process a lot of data in few moments, so I think that it will improve our clinical practice. You need to understand how to use it, because still it's a computer and it's not a human, but it will improve that. And so I think that also on the training part, so with the simulation or augmented reality, it will be also a very good field of improvement for the surgical practice, because you can train better the next generation, you can study better your case. So with augmented reality or 3D printing of the cases, you can fully understand your case and all the risks that are or the structure that are involved, and so you can spare them. So I think that there are many technological fields that are interesting for our practice, and we still need to follow their development, because it's important for our patient. I always thought that we really know a low percentage of the brain function. That's always fascinating me to really know how our brain function, and to know it. Neurosurgery is one of the specialties that give you the opportunity to really touch the brain. So with functional or also with awake surgery, we can really understand how the brain is working. And so that made me fascinating about that. Skull base and vascular are the top technical requirements for us neurosurgeons. So I think that I got fascinating, because to do that kind of surgery, you really need to be a good surgeon and have a good hand. So I got involved in that kind of a field because of this. I want to be on top, and that are my objective.